All right, so here's a person with chest pain, elevated cardiac enzymes. What kind of views are we looking at here?
Short axis and
Yeah, so we're looking at a short axis and a four-chamber view. I've given you the ejection fraction. What do you think of it?
Low.
Well, what?
ish.
Lowish, yeah. So where's the lower end of normal? It's about what? Yeah, so around 55% is the low end of normal. So this ejection fraction slightly decreases, a little bit of hypokinesia throughout. Okay. So with chest pain and elevated cardiac enzymes, what is it that we're going to be concerned about? We're going to be concerned about what? Yeah, sure. You're going to be concerned about myocardial infarction. So if this patient is on your MR scanner, what are you going to do next? Right, so you want to see what happens with myocardial delayed enhancement, right? And also, we have T2 weighted images here. So here's our T2 weighted image. Here's our myocardial delayed enhancement images. So the views that we have there for myocardial delayed enhancement, what are these views? Short axis and two-chamber, right. So what do you have to tell us?
Is there edema? And is there?
Well, you tell me, is there edema?
Yes.
Yes. So where's the edema?
Apical myocardial.
This is the short axis view, right? So which wall is this? Yeah, so that's along the inferior wall there, right? And is there anything abnormal on myocardial delayed enhancement? Are there any regions of abnormal enhancement?
Same region.
Yeah, the same region has this area of abnormal enhancement. So is this a myocardial infarction?
Yes.
No. Who wants to tell me why it is not? Okay, the distribution, right? So myocardial infarcts, the endocardium, there are two criteria for you to say delayed enhancement is due to myocardial infarction. One criteria is it should involve the endocardium. The endocardium is the most ischemic portion of the myocardium because the coronary arteries enter from the epicardium to the endocardium, okay? So the endocardium is the most ischemic portion of the myocardium. If it's an infarct, the endocardium should be involved. This spares the endocardium, right? The enhancement spares the endocardium and actually involves the epicardium. So you could say the same for the edema. The edema also seems to spare the endocardium. So the first criteria for MI is that it should involve the endocardium, the delayed enhancement. The second criteria is what? Should be in a vascular distribution. Now this you can say, well, yeah, it does look like a vascular distribution, but it doesn't involve the endocardium. So this is not myocardial infarction. So given the history, given the findings, your diagnosis here would be acute myocarditis, right? So your diagnosis here would be acute myocarditis. That can present clinically just like myocardial infarction. So that's the topic of our talk here. So myocarditis, the definition of that is non-ischemic inflammatory disease. The most common cause is viral. Nowadays, we do see it associated with COVID, but CMV, Coxsackie, especially in infants, can cause viral myocarditis. There are other causes, other infections that can also result in myocarditis. Non-infectious causes, autoimmune disease, again, we can see it associated with COVID vaccination. Connective tissue diseases, lupus, vasculitis, all of these can also be associated with myocarditis. There are certain drugs that can be associated with myocarditis, immune checkpoint inhibitors for patients on chemotherapy, toxins, radiation therapy, all of that can be associated with myocarditis. So the symptoms, chest pain, shortness of breath, palpitations, most patients, though, do recover spontaneously from acute myocarditis. It is said that 12% of sudden cardiac deaths in young patients is due to acute myocarditis. Complications, patients can go on to develop a dilated cardiomyopathy, about 5% of patients from myocardial scarring and myocardial remodeling. And then they would go on to develop poor ventricular contractions with mitral regurg, tricuspid regurg. Definitive diagnosis would require endomyocardial biopsy. They look for interstitial edema, lymphocytic infiltration, necrosis of myocytes, but you really don't want to go biopsying the myocardium, right? So if there's a way you can make the diagnosis without doing the biopsy, that's where MR comes into play here for myocarditis. So with acute myocarditis, we get edema, we get myocyte injury, and acutely there might be decreased systolic function. In the subacute phase, the edema goes down, but you might start to have some scarring, some fibroblast proliferation. The function improves. Most patients go on to heal, no edema, normal function, although some may be left with some regions of focal fibrosis that we can still see on MR. And then for a very small percent, less than 5%, they go on to develop dilated cardiomyopathy. No edema, but the cardiac function is decreased, and they do have fibrosis that causes the dilated cardiomyopathy. Now for MR, there are what we call the Lake-Lewis, these revised Lake-Lewis criteria for making the diagnosis of myocarditis from MR. These criteria are to be used in symptomatic patients with clinically suspected myocardial inflammation. So you don't use these criteria. These are not screening criteria for asymptomatic patients. These are criteria that we use in symptomatic patients. The sensitivity, specificity, sensitivity of 88%, specificity of 96% for these criteria for accurately diagnosing myocarditis. It comes down to you need one criteria in each category, one T2-based marker of myocardial edema and one T1-based marker of myocardial damage. All right? If there's only one positive criteria, it might still support the diagnosis, but it lowers your specificity. So, for acute myocarditis, we're looking for a T2-based marker of myocardial edema. That could be edema on T2-weighted images. That could be regional or global prolonged T2 time. If you happen to do T2 mapping, actually measuring the T2 of the tissues of the myocardium with MR. T1-based marker of myocardial damage, myocardial delayed enhancement in a non-ischemic pattern. That's what we usually use. That's what we usually look for. But other things that if you do T1 mapping, regional or global elevated native T1 time on T1 mapping, or elevated extracellular volume fraction. We've discussed how we get these, but these are also sequences that you can use with MR to support your diagnosis of myocarditis. So main criteria are here, a T2-based criteria, high T2 signal intensity. So you're looking for regions of edema, okay? Or high T2 values if you do T2 mapping. So these are color-coded, and areas where the values are higher than a certain threshold would show up as a different color than the rest of the myocardium there. So if you do T2 mapping, that's what you would look for. T1-based criteria, so these are criteria for actual myocardial injury. So delayed enhancement, here you can see this epicardial pattern of delayed enhancement. It is sparing the endocardium there. If you do T1 mapping, again, those areas would show up a little bit different in color based on your color map than the rest of the myocardium. Decreased systolic function, pericarditis, these can be supporting but are not absolutely necessary to make the diagnosis. And then those, the wall motion abnormalities, systolic dysfunction, they usually go back to normal when the patient recovers. So here's an example, 31-year-old with viral myocarditis. On T2-weighted imaging, you can see that there's edema here. On myocardial delayed enhancement, you can see the abnormal enhancement and an epicardial distribution and a non-ischemic distribution. So that fulfills both criteria. The native T1 time is elevated on the color map. Native T2 time also elevated with T1 and T2 mapping. Now what happens with recovery 5 months later is that the edema goes away, okay? So there's no edema, but these patients might still have regions of abnormal delayed enhancement. Now that tends to decrease over time. You can see that the delayed enhancement is not as bad as it was when the patient initially presented, but there is some delayed enhancement here. And so that usually represents some scarring. So this represents regions of fibrosis that occurred secondary to the acute myocarditis. So if there's increased T2, T1, and increased extracellular volume fraction, that equals myocardial edema. So that's an indication of acute inflammation. If there's increased T1 and extracellular volume with a normal T2, there's no edema now. So that usually indicates the myocardial fibrosis. So here this would indicate myocardial fibrosis. Okay. Adverse prognostic indicators. The extent of myocardial delayed enhancement, the more there is, the worse the prognosis. That's a strong independent predictor of mortality. More enhancement is worse prognosis. Myocardial delayed enhancement without edema equals fibrosis. That's usually irreversible, and it's usually worse than, if you have myocardial delayed enhancement with edema. As I've said, after the acute stage, the extent of delayed enhancement usually decreases when the patient recovers. Left ventricular ejection fraction less than 40%, high native T1 time, and extracellular volume fraction. So these are all adverse prognostic indicators. So here's another example of myocardial delayed enhancement in somebody with acute myocarditis. You can see it's kind of patchy. It spares a lot of the endocardium, so it's outside of single vascular distribution. So this is a pretty extensive patchy regions of delayed enhancement in a patient with acute myocarditis. And in this particular study, where they looked at patients with acute myocarditis, those patients without delayed enhancement, so this is their survival over time or time to some kind of cardiac event, right? So this is those patients with delayed enhancement, so that they had, their survival was worse than those patients without. So the extent of delayed enhancement does give you some idea of the prognosis for these cases. Now we've talked about myocardial delayed enhancement. It's an indication of myocardial injury. If you have normal myocardium, the gadolinium goes in quickly and washes out quickly. If you have infarcted or injured myocardium, there is delayed uptake of myocardium and there's delayed washout of myocardium. So that's why if you wait about 10 minutes to do myocardial delayed enhancement imaging, you will see that difference, that abnormal enhancement, an indication of myocardial injury. So with infarction, it should involve the endocardial surface. It should be in a vascular distribution. So what distribution is this infarct in? LAD, right? Now that area of dark signal is also an indication of something, right in the middle of an infarct. What is that an indication of?
Thrombus.
Not thrombus, no. That's in the myocardium, that's not the endocardium. Anybody? St. Barnabas, you guys know? Microvascular obstruction, right? What does that tell you about the infarct? It's acute, right? So if you have this finding associated with infarct, that tells you that the infarct is acute. So that's a region of microvascular obstruction. What happens over time is it converts to scar. So 5 months later, that will go away and the whole thing will enhance. Okay? As opposed to myocarditis, where the enhancement can be in more than one distribution, and here it can be mid-myocardial, it may be epicardial, so it tends to spare the endocardial surface. So myocardial infarct starts in the endocardium and then progresses towards the epicardium. It can be partial thickness, it can be full thickness, okay? But it should always involve the endocardium. Here's a very small infarct, here's a more extensive infarct, okay? Now, non-ischemic patterns of enhancement, these can be mid-myocardial, epicardial, or diffuse. So this is mid-myocardial enhancement. You can see that it's in the mid-myocardium. It does not involve the endocardium here. This is an epicardial pattern here. You can see it's following more of the epicardial surface, sparing the endocardium. That's an epicardial pattern of enhancement. And this is a diffuse pattern of enhancement. So here you have diffuse myocardial enhancement. Again, you would not expect this with an infarct because the patient would be dead if the whole, if the whole heart was infarcted. Okay? So with viral myocarditis in the acute stage, you expect to see edema, and you also expect to see although you don't necessarily have to have delayed enhancement, but it does support your diagnosis if you see delayed enhancement in a non-ischemic distribution. There is an entity called infarct-like myocarditis. Patients can present clinically just like they're having a myocardial infarction. They'll have chest pain, ECG changes, elevated enzymes, and the edema usually corresponds to the region of myocardial delayed enhancement. So on T2-weighted imaging, you can see the edema here, and it corresponds nicely to this region of mid-myocardial enhancement in this patient who has acute myocarditis. Another example of somebody with extensive enhancement during the phase of acute myocarditis, 3 months later, much of that went away, although there is still residual enhancement here, and that usually indicates that there is now some fibrosis where this patient had acute inflammation. Okay? All right, so let's move on. So here's a patient, short axis view, 4-chamber view. The heart is dilated. You can see that there's diffuse hypokinesis, right? So there's not very good wall motion. So this is a patient with cardiomyopathy. Now there are two broad categories, when we're talking about cardiomyopathy, there are two broad categories, or two major, I guess, categories that you're trying to decide, right? What are those two categories that can give you a big, poorly functioning heart?
Ischemic versus non-ischemic?
Yes. So ischemic versus non-ischemic. Now, can MR help you to differentiate between those two possibilities?
I guess.
How?
Delayed enhancement.
Well, how does delayed enhancement, how is the delayed enhancement going to help? So ischemic versus non-ischemic cardiomyopathy, here's our delayed enhancement in this particular case. So tell me, is this ischemic or non-ischemic? Why? Oh, we got one vote for ischemic and one vote for non. So which is it?
There's no subendocardial?
Yeah, the subendocardium is spared, right? Again, here we have mid-myocardial delayed enhancement. Here it looks epicardial. The endocardium is spared, all right? So this is a non-ischemic pattern of enhancement. So this patient has non-ischemic cardiomyopathy. With ischemic cardiomyopathy, it's usually because of infarct, right? It's the infarcts that result in that dilated, poorly functioning heart. And so there you would expect an ischemic pattern of delayed enhancement, all right? Now there are various classifications of cardiomyopathies. There's primaries with no known cause, secondary with known cause, unclassified. These are some examples of primary cardiomyopathies. So there are various classification schemes for cardiomyopathies. Secondary cardiomyopathies, they can occur from metabolic disorders, underlying systemic diseases, sarcoid, lupus, rheumatoid arthritis, ETOH, drugs, neuromuscular disease like muscular dystrophy, infection, right after acute myocarditis. We've said like 5% of patients can go on to develop cardiomyopathy. Postpartum cardiomyopathy, we see quite a bit of that around here, postpartum cardiomyopathy also. Then there are these various unclassified cardiomyopathies. Some of them might have characteristic MR findings that we'll talk about. So for dilated cardiomyopathy, the heart is dilated, especially the left ventricle or both ventricles, low ejection fraction, increased end diastolic size, and what happens is as the cells, the myocardial cells die and get replaced by fibrosis, that results in remodeling, and that remodeling results in abnormal pressures along the endocardial surface, which leads to more cells to die and more remodeling. So that's Laplace's law. As the diameter increases, the wall stress increases, and it causes further damage to the myocardial cells. So it's said that myocardial dysfunction begets myocardial dysfunction and adverse ventricular remodeling. So the heart progressively dilates as it poorly functions. So usually when we're talking about cardiomyopathies, we're excluding ischemic causes and we're excluding valvular causes, and then, there are all these other causes that we've kind of just touched upon briefly as various causes of cardiomyopathy, okay? But they all end up in the same place: four-chamber dilatation, tricuspid regurg, mitral regurg, from papillary muscle dysfunction, contractile abnormalities, decreased ejection fraction. There can be regurgitation, mitral regurgitation, but the flow is not a lot, it's not a high volume because the ejection fraction has been reduced. And then mural thrombi is another complication because of stasis of blood flow, especially in the left ventricle, and this is the order in which it occurs, but especially along the endocardium of the left ventricle. So mural thrombi is a complication of dilated cardiomyopathy. Chest radiograph, cardiomegaly. Pulmonary vascular changes may be mild, out of proportion to the heart size. And then just a dilated, poorly functioning heart, especially the left ventricle, dilated heart with decreased ejection fraction. Now, for differentiating ischemic from non-ischemic, so this is a study that much of the literature will refer to. So in this study, patients who had, what they did was they took a bunch of patients with cardiomyopathy. They all had cardiac catheterizations looking for abnormal coronary arteries, and if they did, then they classified those patients as ischemic cardiomyopathy. So in those patients who had ischemic dilated cardiomyopathy, who had coronary artery disease, all those patients demonstrated abnormal myocardial enhancement, as you would expect in the ischemic distribution. Okay, so what you're looking at is myocardial infarction as the cause of that cardiomyopathy, that ischemic cardiomyopathy. Those patients who had non-ischemic dilated cardiomyopathy, about 15% of them had myocardial enhancement that was very similar or indistinguishable from this group, from the ischemic group. And, there's not a good explanation for why. Those patients, the vast majority of patients though, who have non-ischemic dilated cardiomyopathy have no delayed enhancement. So it is not unusual to have no myocardial delayed enhancement in patients with non-ischemic dilated cardiomyopathy. And then a certain percent, almost a third, had non-ischemic delayed enhancement, epicardial or mid-myocardial delayed enhancement, as in this example. What they postulated for this group in the paper was that maybe these patients did actually have ischemic cardiomyopathy, but by the time they got their cardiac caths, either they had, revascularized, or maybe they had a thrombus that revascularized. So that's what they tried to say about this particular group, where the delayed enhancement was indistinguishable from the coronary artery disease group. For causes of non-ischemic cardiomyopathy, idiopathic alcoholic postpartum, these patients tend not to demonstrate myocardial delayed enhancement. Patients who have prior myocarditis and who developed cardiomyopathy, those may demonstrate delayed enhancement, as in this example here. Okay? All right, so I think, we still have a few more minutes. Now, if there is edema, what do we expect to see with the native T1 time? Does it go up or down? Well, yes. Think of it, right? Think of it like water, right? So the T1 time goes up. Native T2 time, up. And the extracellular volume fraction, right. So all of those go up. So if there's edema, all of those things will go up, okay? If there's myocardial fibrosis, what happens to the native T1 time? Up, up. It's pathology usually, think of pathology as increasing the T1, like water, right? Post-contrast T1, what happens to that? That goes down, right, because there's enhancement. So the T1 time went down, and the ECV, up, right. So up, down, and then that would go up, okay? Okay. All right, so let's do this particular case. So over at St. Barnabas, what do you have to tell us about this? Nothing? Anything to say? What? What do you got? Can you guys do better?
There's.
There is mitral regurg. Yes, there is mitral regurg. Is there any other problem? What?
Left ventricular hypertrophy.
Okay, what would you look for?
Septal thickening.
So where there is a flow jet here, see it? Does that start below the aortic valve or above the aortic valve?
Below.
Below. So what's the diagnosis?
It's hypertrophic cardiomyopathy.
Hypertrophic obstructive cardiomyopathy. You can actually see the hypertrophy here along the interventricular septum, right? So this patient has hypertrophic obstructive cardiomyopathy. There's subaortic stenosis. So this stuff is what? The mitral regurg is SAM, from systolic anterior motion of the anterior leaflet of the mitral valve, right? So this is an example of hypertrophic cardiomyopathy. So this is idiopathic myocardial hypertrophy, autosomal dominant with variable penetrance, can also be associated with neurofibromatosis, Noonan's, or this other syndrome I've never heard of. Okay. So criteria, thickening of the left ventricular wall greater than 15 millimeters at end diastole with no known cause, so the patient should not have hypertension. These patients often have increased ejection fraction. When you actually measure it, it turns out to be increased, which is not a good thing, actually. We'll talk about why later on. The hypertrophy can involve the whole chamber, concentric, the free wall, the interventricular septum, that's the type that's most common in the United States, or the apex of the left ventricle, so that form is more common in Japan. So these are synonyms: asymmetric septal hypertrophy, DUST, IHSS, all synonyms for hypertrophic cardiomyopathy. When there is high velocity flow through the outflow tract, there's a Bernoulli effect, and it can suck the anterior leaf of the mitral valve into the outflow tract, which further aggravates the outflow tract obstruction, but then leads to mitral regurgitation. So SAM, systolic anterior motion of the anterior leaf of the mitral valve, results in mitral regurgitation, which can also be associated here. So subaortic stenosis, hypertrophy, and your bonus finding of mitral regurg from SAM, from systolic anterior motion of the anterior leaf of the mitral valve. So this anterior leaf of the mitral valve kind of gets sucked into the outflow tract. Look at all that hypertrophy, and then that results in the mitral regurg and the flash of mitral regurg that we can see in these patients. Okay. Now, for this particular case, I will tell you that this patient has hypertrophic obstructive cardiomyopathy. It's the same patient. These are two different sequences. We're looking at a left ventricular outflow tract view. We can see the hypertrophy. But notice that in this sequence, we can see the turbulent flow here along the outflow tract much better than we can in this sequence. Mehmet, why is that? Why is it that we can see the turbulent flow here much better on this sequence than we can on this sequence?
Because this is a spoiled grass?
This is a spoiled grass sequence, right? And this one is?
SSFP?
This is SSFP, right. This is Fiesta. And so that's a difference between those two sequences. So, same patient as I've said. So with spoiled grass, these sequences are sequences that were used in the very beginning, or older sequences for cardiac imaging. And these are usually the standard sequences for cardiac imaging, for bright blood imaging, these SSFP, or balanced gradient echo sequences. What's different about the spoiled grass sequence, and these are sequences that are still used in body imaging, notice that the TE is longer here. And the longer TE on these spoiled grass sequences allows you to see the phase disturbances where you have turbulent flow. So we talked about this last time when we were looking at imaging the valves, how the morphology of the aortic valve sometimes can be better seen on the spoiled grass sequence than it can on the SSFP sequence. The same thing is true for turbulent flow. So if you're looking for turbulent flow, the spoiled grass sequences are going to be more sensitive than the SSFP sequences. They're not as pretty. You have better signal to noise on the SSFP sequences. You can see that these images are uglier, but these are more sensitive to disturbances in flow. Okay? Now, when we have hypertrophic cardiomyopathy, there are the different forms we can have. We can have this asymmetric form where there's hypertrophy along the outflow tract. So that's typically in the United States, that's what can cause the outflow tract obstruction. You can have concentric hypertrophy where the hypertrophy is diffuse all around the left ventricle. You can have midventricular hypertrophy, as you see here, and then you can have this hypertrophy that is more towards the apex of the ventricle. This is more common in Japan. This can be associated with what looks like an aneurysm here in the apex of the ventricle when you have this form of hypertrophic obstructive cardiomyopathy. Now, we can also see delayed enhancement in these areas of hypertrophy in these patients with hypertrophic cardiomyopathy. And the more delayed enhancement there is, the worse the prognosis. So the thinking is that this delayed enhancement may indicate regions of fibrosis and can increase the risk for arrhythmia. So these areas of delayed enhancement then could represent regions of fibrosis within the areas of hypertrophy. And so the more delayed enhancement you have, the worse the prognosis sometimes in these patients. Also, it's typical to have the delayed enhancement. It's what's called the hinge point up here, where you see the insertion of the right ventricle here on the interventricular septum. Now, there are things on MR that are associated with worse prognosis. So the thicker the wall, especially when it gets greater than 30 millimeters in thickness, that's associated with the worst prognosis. And that can be an indication for placing an AICD, because arrhythmia is the most common cause of death in these patients. So normally it should be less than 12, and if it's greater than 15, then it fulfills criteria for hypertrophic cardiomyopathy. But when it gets up to 30, greater than 30, then those patients are really at increased risk for sudden death. The more delayed enhancement there is, if it involves more than 10 to 15% of the myocardium, again, that's associated with increased mortality, apical aneurysms, a gradient, the higher the gradient along the left ventricular outflow tract, then that means that the obstruction is worse. If the left ventricle gets big, the bigger the left ventricle. And then in some cases, patients can have what's called burned out hypertrophic cardiomyopathy, where the ejection fraction actually decreases because it really has affected the left ventricular function. So all of those are associated with increased mortality. Okay, so over at Beth Israel, what happens if we have a hypertrophic cardiomyopathy? What happens to the native T1 in the area of hypertrophy? Does it go up or down? All right, you guys here? Up, right. So pathology usually increases native T1. The post-contrast T1, does that go up or down?
Down.
Yeah, that goes down because we can see the enhancement. This is an enhancement here. And so here on this color-coded image where the T1 is high, it's coded more in yellow, so you can see that that area is brighter. And the ECV, what happens to the ECV?
Up.
Yeah, so the ECV goes up. So with hypertrophic cardiomyopathy, the native T1 goes up, the post-contrast T1 goes down, and the ECV goes up. So this is a patient who has hypertrophic obstructive cardiomyopathy. Over at St. Barnabas, what was done for this patient? Yes, so this patient has had an ablation procedure. So you can see here on the T2 weighted imaging, it's bright because of edema where the ablation was done. And then on the myocardial delayed enhancement, you're actually looking at an infarct. So what ablation is an iatrogenically induced infarct here along the area of hypertrophy. So this dark region in the region of the infarct represents what? Microvascular obstruction, right. So this is image in the acute phase. Okay, so the idea is that by iatrogenically infarcting that region, it will result in atrophy and then relieve some of the obstruction. the first line of treatment is usually surgery in these patients with hypertrophic obstructive cardiomyopathy, but ablation therapy is also an option. So this is pre-ablation. You can see the hypertrophy, and post-ablation, there's been some atrophy there to relieve some of the outflow obstruction in this patient. Okay, and so in the acute phase, we will see edema, and then we see the enhancement right there in the region of the infarction. So here's another example. So pre-ablation, you can see the hypertrophy in the outflow tract. You can see the turbulent flow in the outflow tract and some mitral regurg from SAM. And this is acutely after the ablation. Here you can see the delayed enhancement. And then 11 months later, you can see that there's been atrophy in the region of the ablation. We still have delayed enhancement because that region of the myocardium was infarcted, but it relieves some of the obstruction there in the outflow tract of the left ventricle. Okay. Now, one thing that might also be in the differential is athlete's heart. So athletes, very highly trained athletes, can also develop some hypertrophy of the left ventricle. And when we measure the thickness of the left ventricular wall, when it's greater than 15, then it's usually definite evidence for hypertrophic cardiomyopathy. But you can be in this gray area of 13 to 15 millimeters there of hypertrophy. And sometimes, athletes, hypertrophy can fall within that region. So they might have some mild left ventricular hypertrophy. They will have increased left ventricular volume, which can be a difference there between hypertrophic cardiomyopathy and athlete's heart, is that the actual volume of the left ventricle does increase in highly trained athletes, and they will not have any diastolic dysfunction. So when you look at an athlete's heart, you don't have to worry about these numbers, but the basic idea is that the volume of their ventricle, the left ventricular end diastolic volume, actually increases, and it helps them to pump more blood. So when you look in systole and diastole here, you can see that the volume of the ventricle does increase, even though there is some mild hypertrophy. On the other hand, if you look at somebody with hypertrophic cardiomyopathy, they actually have an increased ejection fraction. And you might think, well, that's good to have an increased ejection fraction, but it's actually not good in this case, because remember that the ejection fraction is a ratio. And the reason that the ejection fraction goes up in these patients is because at end systole, look at how the cavity is obliterated by the hypertrophy. So the volume of the cavity here is lost. It's kind of obliterated during end systole because of the hypertrophy of the left ventricle. So this obliteration of the left ventricular cavity at end systole, that's another finding that is also associated with hypertrophic cardiomyopathy. Okay? All right, so let's move on to this case. So this patient has symmetric myocardial hypertrophy, and often these patients are given a diagnosis mistakenly of hypertrophic cardiomyopathy. However, the findings on myocardial delayed enhancement in these cases can be characteristic. So over here, what disease are we talking about? So this is Fabry's disease. So what is the finding on myocardial delayed enhancement that's characteristic for Fabry's disease? Oh, is there a finding there on myocardial delayed enhancement? Well, what is the finding?
The myocardial enhancement in the inferior wall.
So there's along the lateral wall, actually, and it's near the base of the heart. All right, so that finding can be characteristic for Fabry's disease. So these patients also develop hypertrophy of the left ventricle. So this is an autosomal recessive disorder, and it's caused by deficiency of this enzyme, and that results in intracellular glycosphingolipid deposition. And that results in the left ventricular hypertrophy, which can mimic non-obstructive symmetric hypertrophic cardiomyopathy. So they can have complications like arrhythmia, valvulopathies, or restrictive cardiomyopathy. But the myocardial delayed enhancement, that mid-myocardial delayed enhancement in the inferolateral wall of the left ventricle, can be characteristic, and about 50% of patients with Fabry's disease may demonstrate that pattern of enhancement. So with Fabry's disease, what happens to the native T1?
It's actually down.
Why?
It's one of those diseases that has a lower native T1 because of the deposition
Of
of glyco.
its fatty material.
Fatty material.
Right, and fat decreases the T1. The extracellular volume fraction?
Increase.
Well, the extracellular volume fraction is actually normal because this is an intracellular problem, not an extracellular abnormality. Now, the thing with the T1 is it can get kind of, there's a little bit of confusion here, or it can get confusing. So where you have the intracellular lipid deposition, the native T1 can actually go down. But where we have the enhancement, that actually indicates some fibrosis. And so because of the fibrosis, that would tend to elevate the T1, but that can actually counteract the drop of the T1 because of the intracellular lipid. And so in those areas, the T1, the native T1, can actually be close to normal or normal. So that's called pseudo-normalization. So a bit of a confusing picture there with Fabry's disease, okay? But that delayed enhancement, that's what we would look for. That could be a characteristic finding. Okay, so here's our next case over at St. Barnabas. What's wrong in this case? What's abnormal? Anybody at St. Barnabas? Beth Israel? Anything abnormal in this case? Right. Yeah, there's myocardial hypertrophy. Now already, in terms of your differential of myocardial hypertrophy, we've covered two things already that are in that differential, two diseases we've covered already. What are those two diseases that we've already covered? So hypertrophic cardiomyopathy and Fabry's, right? Both of those can give you myocardial hypertrophy. Now, what else might give you myocardial hypertrophy? Well, if the patient has systemic hypertension, right? So that's something that you want to know because that can also cause hypertrophy of the myocardium. But let me show you this, and then you tell me what's going on. Not T1, what is that? What are those letters? What does TI stand for? You guys want to help? Inversion time. So what is this slide showing you in this case?
Amyloid.
Why?
The myocardium is not suppressing it.
Right. So as we're changing the inversion time, looking to suppress the myocardium, we are not able to suppress the myocardium because it is diffusely enhancing. And that might be your first indication that you're dealing with a case of amyloid. Okay? So amyloid can give you diffuse enhancement on myocardial delayed enhancement. And an indication of that is when you try to suppress the myocardium, you can't suppress the myocardium because it's enhancing. So that's what we would see with amyloid. Now, normally, as we go through our inversion times from lowest inversion time to the higher inversion time, the blood pool will turn dark. The blood pool normally suppresses before the myocardium suppresses. And you can see that here, the blood pool will turn dark here, there it turns dark, and then the myocardium later on, after the blood pool turns dark with a higher inversion time, then the myocardium will turn dark. So here I've kind of illustrated it for you. TI of 100, 160, you can see the blood pool is dark, has suppressed, but the myocardium is not suppressed yet. It's not until we get to 270 that in this particular case we're able to suppress the myocardium. So normally the myocardium will suppress at lower inversion time numbers than the blood pool. But what happens with amyloidosis can be the opposite. So there's the blood pool in there, and then we have the myocardium out there. And as we are increasing, as we're progressing towards increasing the inversion time, we can see that the myocardium here will turn black before the blood pool actually turns black. So as we play that again, myocardium turns black, and then the blood pool turns black. And so I've illustrated that for you here. So at a TI of 140, the myocardium here is dark, has suppressed, but the blood pool is not, and the blood pool doesn't suppress until the higher inversion time number. So this can occur with amyloidosis. So what happens is, normally the blood pool will have more gadolinium than will the myocardium. So the null point for the blood pool will be lower than for the myocardium. But it can reverse when you have amyloid, because the gadolinium gets deposited in the soft tissues and kind of gets sucked out of the blood pool very quickly. And also because of the amyloid in the myocardium, it kind of absorbs the gadolinium. So then the myocardium the myocardium enhances, but the inversion time of the myocardium, the optimal inversion time or the null point of the myocardium, can be lower than that of the blood pool. So that might be an indication that you have amyloid. Now there are different forms of amyloid. There's AL amyloidosis, which results in light chain deposits in any organ, including the heart. There's this transthyretin form of amyloidosis, and that's this is produced by the liver. And there are two forms of that. There's a wild type that can occur in older men. It's a non-mutated protein, and then there's the mutant type, which occurs because of the mutation of the transthyretin gene. So there are these different forms of amyloidosis that might affect the heart. So with amyloidosis, what happens to the native T1?
Increase,
Yes, so the T1 would go up, the post-contrast T1
decrease,
decrease, right? It enhances, and then the ECV would
increase.
increase, right? So the native T1 goes up because of enhancement, the post-contrast T1 goes down, and the ECV would go up. Now, T1 mapping can be very useful for amyloidosis because one of the problems, of course, with amyloid is poor renal function. So that might impair your ability to use gadolinium sometimes, depending on what contrast agents you're using in these patients. And so if you can't give, for whatever reason, if you can't use gadolinium, then you can do T1 mapping to look for the changes in the myocardium that are associated with amyloidosis. Okay? Now this gets us to the topic of restrictive cardiomyopathy. So restrictive cardiomyopathy usually occurs because of an infiltrative disorder affecting the myocardium, and that causes reduced left ventricular compliance. The left ventricle gets very stiff. It can be idiopathic, or it can be secondary to infiltrative disorders like sarcoid hemochromatosis or amyloidosis. There are these other disorders that can also be associated with restrictive cardiomyopathy. So myocardial disease, infiltrative disorders can be a common cause of restrictive cardiomyopathy. There are also, of course, there's diabetes and idiopathic, which can also cause it. And then endomyocardial fibrosis can also cause restrictive cardiomyopathy, and storage diseases can also be associated with restrictive cardiomyopathy. What happens is the stiffening of the walls of the ventricles prevent diastolic filling, so the patients can develop diastolic dysfunction. So the walls will thicken, and the right atrium and the left atrium can actually dilate because of the diastolic dysfunction, resulting in increased filling pressures. And then you can get pulmonary venous hypertension, dilated SVC, IVC, all of that can occur with restrictive cardiomyopathy. So it can mimic constrictive pericarditis because of impaired diastolic filling, or sometimes even mitral stenosis because of enlargement of the left atrium. So this picture here, where we have myocardial hypertrophy with dilatation of the atria, so that can be a finding associated with restrictive cardiomyopathy. And we see that also in this case of amyloidosis, the diffuse enhancement, which is typical of amyloid, but also the dilatation of the atria here, which we can also see associated with restrictive cardiomyopathies. And amyloid can be a cause of restrictive cardiomyopathy. All right, so let's not worry about this part here, but here's a nice differential for causes of left ventricular hypertrophy. So we've covered hypertrophic cardiomyopathy. Amyloid can give you left ventricular hypertrophy, Fabry's disease, hypertensive heart disease, aortic stenosis can give you left ventricular hypertrophy, and we've also talked about athlete's heart, which can be associated with mild hypertrophy of the left ventricle. Okay. All right, so over at St. Barnabas, this patient has arrhythmia and systolic dysfunction. So what do you notice on these bright blood images? Yeah, so you're right, there's globally decreased function, right? So the wall motion is kind of decreased globally. It's hypokinetic all the way around, okay? And then when we look at myocardial delayed enhancement, we notice that there are these multifocal regions here of myocardial delayed enhancement, not in a pattern associated with infarctions. A lot of it is mid-myocardial. It's more than one vascular distribution. Some of it is also globular, as you can see. Now, on the MR, there were some other interesting findings also. You can see that the lung parenchyma here looks abnormal in this patient in the hilar regions. And even the chest x-ray kind of looks funny here. So what disease do you think we're discussing here? What could this be? Yeah, so this is a patient with sarcoid, has this, looks like some hilar adenopathy, and these upper lung parenchymal changes would turn out to be regions of fibrosis. So this is a patient with sarcoid. You can see it says nodularity also has adenopathy, and we see a little bit of calcification within these lymph nodes. So sarcoid can also affect the heart. So this is an example of cardiac sarcoid that can also give you, again, these multifocal regions of enhancement. And so if I just showed you this, of course, your differential would be, myocarditis versus sarcoid, scarring from myocarditis versus sarcoid. A pattern that has been described with sarcoid is enhancement of the interventricular septum, especially closer to the right ventricular portion of the interventricular septum. So that pattern has been described with sarcoidosis. And the regions of the heart affected with sarcoid can lead to cardiac dysfunction. So arrhythmia is a common complication of cardiac sarcoid. So the conduction bundles occur in this region. So if that part of the heart is affected by sarcoid, it can affect conduction, and arrhythmia is a complication of cardiac sarcoid. Aneurysms at the base of the ventricle also can be seen with sarcoid. Sometimes patients can also develop mitral regurgitation here because of the affecting the insertion of the papillary muscles there. So with sarcoid, sometimes these patients can have these areas of increased signal on T2 weighted imaging. So it's important to do T2 weighted imaging in your protocol. If you are examining a patient with sarcoid, we would look for, of course, these areas of abnormal delayed enhancement also. Here's a very late stage where this patient has restrictive cardiomyopathy, very poor cardiac function, but also you can see the massively dilated atria in this patient with restrictive cardiomyopathy from sarcoid. This is a patient who has an aneurysm of the base of the left ventricle. That's an unusual location for a cardiac aneurysm. So that finding can also be associated with sarcoid. And as I've said, it's important in your protocols when you're examining somebody for sarcoid to do T2 weighted imaging, because these areas of high signal on T2 might correlate, or many times do correlate, with the areas of abnormal enhancement in these patients with sarcoidosis. So in patients with sarcoid, what's going to happen to the native T1? The native T2. Yep, post-contrast T1, decrease in ECV. So native T1, native T2 go up, post-contrast T1 goes down, and the ECV would go up. By the way, there's another study that can also be done in patients if you suspect cardiac sarcoid. What is that study? Yeah, PET. Now, there's an important thing to remember, though, if you're going to do a PET study in a patient to rule out sarcoid of the heart. What is that? Well, does the myocardium light up on a PET scan?
Yeah.
Yeah. So how are you going to differentiate that from sarcoid?
Sam.
Anybody know? It involves the preparation, right? So the patients have to be fasting for this, because you want to switch them away from glucose, myocardial glucose metabolism. So the preparation is very important. If you're going to evaluate a patient for myocardial sarcoid, the preparation for that is a prolonged fasting period before you do your PET CT. Okay. All right. So let's see. Anybody at Beth Israel? We have a 42-year-old woman here with decreased ejection fraction on echo. Do we notice anything here? Yeah, so the myocardium is dark and the liver is dark, so what are we thinking about? Yeah, so we're thinking about iron deposition disease, so what is it that we should do here? Well, the patient's on your MR scanner. Okay, so here you want to do T2 star weighted imaging. So compare that to the normal patient, right? Look at the liver here. So the normal patient, the myocardium is not as dark. That might be hard for you to notice though when you're just looking at bright field imaging, but look at everything else. Notice how dark the liver is. So this is what normal should look like. This is our patient with iron deposition disease. All right? So on CT, of course, the liver can also be high in attenuation. And as we've said, if we're going to evaluate iron overload with MR, we want to do T2 star weighted imaging. So in a normal patient, when you're doing T2 star weighted imaging, as you're increasing the TE, we notice that the signal does not really decay that quickly. The signal decays gradually. But because of iron deposition within the myocardium, as you increase the TE, the signal decays much faster. And so you can construct these signal decay curves and calculate a T2 star time constant. And with iron overload, you can see that that T2 time constant is much lower than it would be in your normal patient. The magic number for the T2 star time constant is what? 20 milliseconds, right. So if it's less than 20 milliseconds, then that's evidence on MR that you have significant iron deposition. So the idea is that these patients would be treated with chelating agents, and when you bring them back for follow-up imaging, what should happen?
T2 star should increase.
Yes, so the T2 star should go up if your treatment has been effective, okay? So with iron overload, not only will the signal from the myocardium be darker, but look at everything else and notice that the signal in your liver also would be darker in these patients. And then here's color-coded scheme here, so it can color-code the parts of the myocardium where your T2 star is below a certain threshold value. So, here all of it is red, so indicating that there's, significant myocardial iron deposition in this particular patient there, okay? So what's going to happen here with the iron overload in the T1, T2, and ECV? What happens to the native T1?
Goes down.
It goes down. The native T2 down, ECV. Well, ECV is not affected because this is not an extracellular problem, right? This is an intracellular problem here. So the native T1 and the native T2 goes down because of the effects of iron there, the susceptibility effects of iron. And it's because it's an intracellular problem, the extracellular volume fraction is actually normal here. Now, it turns out actually that, although, we talk about using T2 star weighted imaging, there are studies that have shown that doing T1 mapping in these cases when you're looking for iron deposition, can work out better than the T2 star values, right? So you'd want to do both if you have the ability to do both in these patients, okay? All right, so over here. So what's abnormal here when we look at this case? Yeah, so we see here on myocardial delayed enhancement and also here on the breitbart imaging, there are these filling defects along the apex of the right ventricle, along the apex of the left ventricle. We notice that they are not enhancing, so that is thrombus, right? What is enhancing on the delayed enhancement images? The subendocardium, right. So the subendocardium is enhancing here along the left ventricle and along the right ventricle. So can we put that together? What lab test would be abnormal for this patient? Right, so what do we call this? Yeah, so this is Loeffler's endocarditis. This is caused by increased eosinophils, okay? So eosinophilic endomyocardial fibrosis or Loeffler's endocarditis. And so what happens here is that these patients develop subendocardial fibrosis, hence the enhancement, and because of the damage to the endocardium, they can develop mural thrombi. So these areas that don't enhance. So this represents a mural thrombus here on your black blood imaging, and it does not enhance. We do see the subendocardial enhancement. So what happens with these disorders, it's caused by hypereosinophilia, and what happens is when the eosinophils, these eosinophils, release their enzymes, they cause damage to the myocardial surface, to the endocardium, and that results in fibrosis, and that fibrosis then results in, of course, the delayed enhancement, but also because of that damage can induce formation of mural thrombi. So subendocardial fibrosis with mural thrombi, that's a feature of Loeffler's endocarditis. Also, the ventricles become stiff, so this is also a cause of restrictive cardiomyopathy. And then, there's a rarer form that can be found in equatorial Africa. Usually this is caused by diseases that cause elevated eosinophils, peripheral eosinophilia. So it can be caused by idiopathic hypereosinophilic syndrome. It can be associated with Churg-Strauss, eosinophilic granulomatosis with polyangiitis. They might have increased T2 signal along the subendocardium, enhancement in the subendocardium, and these dark areas then represent regions of thrombi that can also occur. There's an acute necrotic stage where you get tissue damage because of the eosinophil degranulation, thrombotic stage where thrombi form along the damaged endocardium, and then that can go on to a fibrotic phase where patients develop restrictive cardiomyopathy. So chronic eosinophilic disorders, elevated eosinophils, can also cause damage to the heart and result in what we call Loeffler's endocarditis. Okay? All right, so over at Beth Israel, what do we notice about this case? Well, what kind of view is this? Short axis, right? What chamber is this? Okay, so that's the right ventricle. And then here's the right ventricle here too. So what's wrong with the right ventricle? It's dilated, but what else is wrong with it? What do we call this wall motion abnormality here? This is called what? Bulges out in systole, it's called? Guys, dyskinesia, right? So there's dyskinetic wall motion here especially along the outflow tract of the right ventricle. And you're right, this is associated with ARVD. Sometimes these patients might also have delayed enhancement in the areas of the heart that are affected, but that is not absolutely essential to make the diagnosis. So arrhythmogenic right ventricular dysplasia, it's a cardiomyopathy associated with arrhythmias and sudden death in young individuals. So the right ventricular anterior wall is replaced by fatty or fibrous tissue. So you get dilatation of the right ventricle, poor functioning of the right ventricle, but also a risk of arrhythmias and sudden death. So it's associated with ventricular arrhythmias. It's said that 20% of cases of sudden death in less than 35 years of age can be caused by this, and it's from that fatty or fibrofatty infiltration of the right ventricular myocardium. It is familial in 30 to 50% of cases, autosomal dominant with variable penetrance. That's why if one person in the family is diagnosed with this disorder, they may send other family members for screening for this disorder. Now, there are major MR diagnostic criteria, and it requires regional right ventricular dyskinesia, so it's one qualitative and one quantitative criteria. Regional right ventricular dyskinesia, meaning you're looking for those areas where there's abnormal wall motion, where the wall bulges out, and then one of these quantitative criteria. So either this increased right ventricular end diastolic volume index, and we have these numbers for males and females, or reduced right ventricular ejection fraction. So either of those combined with regional right ventricular dyskinesia, that fulfills major MR diagnostic criteria for the diagnosis. So this is what you're looking for to make the diagnosis. However, it's important to realize that imaging alone is not sufficient to make the diagnosis. So it also requires family history, ECG and Holter findings, sometimes histopathology and genetic analysis. So it's a complicated diagnosis, and I would, refer you to the literature if you're interested in that. But as far as the supportive MR criteria for making the diagnosis, here they are presented to you here. So you might have fat within the right ventricular wall, but that is not a specific finding, and that is not a major MR criteria. Thinning of the right ventricle, aneurysms, dyskinesia, especially along the outflow tract, increased size of the right ventricle, and as we've said, wall motion abnormalities, and even abnormal enhancement in the anterior wall of the right ventricle. Again, this is not a major criteria for making the diagnosis. So it used to be, that people were looking for fat, high signal here on T1 weighted images along the outflow tract of the right ventricle to make the diagnosis. It's something you can see associated with ARVD, but it is a non-specific finding, and this is not a major criteria for making the diagnosis of ARVD based on findings on MRI. So abnormal wall motion, areas of dyskinesia, this is something that you're going to be looking for in these patients. So you can see this bulging out of the right ventricle, especially along the outflow tract here. So dyskinesia along the free wall of the right ventricle, that is something that you are looking for to make the diagnosis in these cases. And this particular appearance of the case we started with, where it's got kind of like, looks like an accordion, the way the free wall crumples. So that is also a specific feature for ARVD. So if you see that crumpling of the free wall of the right ventricle, so that morphology is specific for ARVD. Okay? And then, as we've said, delayed enhancement you might also see, but it is not a major criteria for making the diagnosis. Okay, over at St. Barnabas, what do we see? What do we see about this case? What do we notice here? Yeah, so here we have increased trabeculations of the ventricle, so the diagnosis here would be left ventricular non-compaction. What are the complications of this? Complications of non-compaction? Guys? Right? You can develop clots in here, you can develop emboli, arrhythmias, cardiomyopathy from myocardial dysfunction, those are all complications. So the heart becomes sponge-like with prominent trabeculations, and clots can form within those trabeculations. In embryology, compaction proceeds from the epicardium to the endocardium from base to the apex. So the apex is the last part of the heart that really compacts down and has that normal appearance. So when we have non-compaction, it's more likely to see those trabeculations in the apex of the left ventricle than anywhere else. So non-compaction is the abnormal persistence of that trabeculated myocardium with deep intratrabecular, those intertrabecular recesses. We can have ischemia, arrhythmia, systemic emboli from clots that form in there. Patients, there's a wide spectrum. Patients can be asymptomatic to progressive left ventricular failure. To tell you the truth, most of the cases that I see, the patients are asymptomatic because what happens is they notice it on echocardiography and then they send the patient for MR to confirm it, okay? And many of the cases that I see, the patients are completely asymptomatic from this entity itself. So that is something to realize. Not all patients with this entity are necessarily going to be symptomatic from it, but some patients can, and this is a cause of cardiomyopathy. Okay, so here's a very dramatic example. Here you can see all these trabeculations on this left ventriculogram. Now there are MR criteria for making the diagnosis. What are the MR criteria for making the diagnosis of non-compaction? Anybody know anywhere?
Ratio.
What's the magic number? 2.3 is the number, correct. So What you do is you look at end diastole and you measure the thickness of the trabeculated myocardium and you compare that to the thickness of the compacted myocardium. And then end diastole, if that ratio is greater than 2.3, then that fulfills MR criteria for non-compaction of the ventricle. Right? So I noticed also that on T1 weighted images, you can sometimes see it a lot better too, right? Kind of dramatic here on these T1 weighted images, this non-compaction of the left ventricle in this case. And then here we can see on the bright blood images, you can see all of that trabeculated myocardium very nicely. Notice that it gets worse as you progress towards the apex of the left ventricle, which is typical of left ventricular non-compaction. You might also see delayed enhancement in these regions of trabeculation, so that's a finding that can also be associated with non-compaction of the left ventricle. Okay, so you guys over here, aneurysm at the apex of the ventricle. Certainly the first thing you think about is infarction, but my question for you is, what non-ischemic etiology, and notice also there's delayed enhancement in that region, what non-ischemic etiology could cause this? Fibrosis, delayed enhancement, aneurysm in the ventricle. Any idea? Chagas disease. Somebody's done reading here. Correct. So, this is a parasite, tropical parasite, and spread by the kissing bug, can be asymptomatic for decades. 1/3 can develop disease progressing to heart failure or dangerous arrhythmias. So it can lead to progressive myocardial fibrosis and aneurysms affecting the left ventricle. So somebody with aneurysms of the left ventricle and they don't have a history of coronary artery disease or infarctions, Chagas disease is something to think about there. So they develop progressive myocardial fibrosis and aneurysms of the ventricle. MRI, of course, will show the aneurysms, and we might also see the delayed myocardial enhancement because of fibrosis in those areas of the ventricle that are affected. Okay? All right, so over at Beth Israel, this is a 63-year-old woman with chest pain, ST segment elevation, abnormal ECG, elevated cardiac enzymes. The first thing that comes to your mind is what? With that history, what's the first thing you're going to think about? What are you going to think about? I can't hear you. Sure, myocardial infarction. Is there a finding here of what kind of view is this? This is a chamber view, right? Is there a finding on the two-chamber view here that is associated, might be associated with MI? Is this with contrast? This is not. This is bright blood. So is there a finding here that can be associated with myocardial infarction? Where's the wall motion abnormality? In the apex, right. Notice that the apex is not contracting. So there's a wall motion abnormality there in the apex of the ventricle. So here on this left ventricular gram, we can see that that does certainly confirm that wall motion abnormality there in the apex of the ventricle, right? That apex is not contracting well, okay? So we need to look at myocardial delayed enhancement. So here is our myocardial, here, by the way, here's a T2 weighted image. What do you see on the T2 weighted image? Correct, there is edema in the apex of the ventricle, and certainly that can be seen with acute myocardial infarctions. What about on delayed enhancement? Is this a myocardial infarct? Yes or no? Can't hear you. No, right, there's no delayed enhancement. So when we look at the pattern of edema in this particular patient, why is the pattern not consistent with myocardial infarction? Correct. It goes all the way around. It involves multiple vascular territories. So that pattern is not consistent with infarct. So here's the pattern in the patient we're talking about. Here's the patient with an infarct along the LAD, and you can see that this is in a vascular distribution and this is not in a vascular distribution, all right? So we have a patient with edema, with wall motion abnormality in the apex of the ventricle, no delayed enhancement. What disease are we thinking about here? This is Takotsubo cardiomyopathy, right? And this is usually self-limited, and you can see that a couple weeks later, all of that edema goes away. So this is Takotsubo cardiomyopathy, named after a Japanese pot used to catch an octopus, Takotsubos. So it's called stress-induced cardiomyopathy. It may be caused by coronary spasm, myocardial stunning from elevated catecholamines. So we look for wall motion abnormalities, especially affecting the apex of the left ventricle. There is no obstructive coronary artery disease. There's no myocarditis or pheochromocytoma to explain it. They can have an abnormal ECG. It's usually self-limited. But it is not, so it's wall motion abnormality, but it is not from an infarct. So with Takotsubo, there can be edema affecting the myocardium. They can have wall motion abnormality, especially in the apex. There are no perfusion defects. There is no myocardial delayed enhancement here. So there is no infarction associated with Takotsubo. The differential diagnosis for acute chest pain, ECG changes, and elevated cardiac enzymes with normal findings on cardiac cath include acute myocarditis, infarct with recanalized coronary artery, and Takotsubo. So with Takotsubo, native T1, up, native T2, increase ECV. Yeah, all of those go up. Remember that there is edema, so there is some pathology here with Takotsubo cardiomyopathy, okay? All right, and then I've given you this too, going through the various disorders and how it might affect the extracellular volume fraction in the native T1. Notice that with Fabry's and iron at the deposition, these are intracellular disorders that they don't affect the ECV in those cases. So that might be the tricky question that might come up on your exams, okay? So let us move on now to the quiz.